We see today that the numbers have started increasing in many states, and questions arise after the South Africa experience about the validity, the efficacy of these vaccines in the light of these new developments. So today we have some really eminent speakers who would, come to us talking about the various aspects. They'll probably answer all the questions that you have on the virus and the vaccine. And we have three speakers with us. We have Professor Dr. V. Ravi, who is the Nodal Officer for Genomic Information of SARS-CoV-2 with the government of Karnataka. He was formerly Senior Professor and Head, Department of Neurovirology, and Registrar and Dean of Basic Sciences at NIMHANS, Bangalore. We welcome you, sir. We also have with us someone you might have seen on television for the longest while. For the last 1 year, Dr. Ram Subramaniam has been on TV talking about the virus. He was also on the task force to inform the Tamil Nadu government of various aspects in the, in the handling, the state's handling of the virus. I know he played a very important role there. He's a consultant infectious diseases and tropical medicine at Apollo Hospitals, Chennai. And he's been sort of for those from outside of the state, he's been sort of the media's, media advisor of sorts, because every time we have a doubt, call Dr. Ram Subramaniam. So thank you very much and welcome to this conversation, Dr. Ram Subramaniam. We also have with us Dr. Saranya Nandakumar, whom I have also known for a long while. She is the Technical Director and Chief Microbiologist at Neuberg Diagnostics. She has, qualified in medicine from Chennai, and she will be able to give you a lot of information about testing primarily. And I think Dr. Ravi is available for genetic variations and the vaccine, and your questions on the aspects of treatment and vaccine, of course, and what we can do, what are the protocols that we can adopt, can be directed to Dr. Ram Subramaniam. So just to spark off some early discussion, I think the pertinent point today is what is happening in India itself. Is it true that we have entered the second phase of COVID? I think Dr. Ram Subramaniam, you did say that early on, I think as early as October, you did say there might be a second wave sometime after February 2021. So is this a second wave? Dr. Ram Subramaniam, can we start with you and then we'll move on to Dr. Ravi as well?
Yeah, thank you very much. It's a pleasure to be with you this afternoon. The questions which everybody, I remember in the later part of 2021 were asking is, we are now coming down on the first wave, would we get a second wave? And, it was no great prediction in the sense that it didn't need astrology or astronomy to predict. It was basically common sense and a little bit of history. We saw that most countries which were ahead of India by 3 to 4 months, whether it was US, Europe or UK or even Brazil, they all had a second wave, usually a few months down the line. And it was inevitable. And I didn't see, shall I say, any reason why India should be protected. Probably the severity of the second wave will be much milder in India when compared to the others, because the population in India is much younger. We know that only 6% of the population is above 60. So it is just natural that the second wave, even though it will come, will be far milder than what US or UK or Europe is witnessing. That is what is beginning to happen. We are seeing a surge in several states, including Tamil Nadu. We are coming across increasing numbers, but I only hope that this will not be as bad as the first, and it will hopefully fizzle out in a shorter time than the first wave. So I just hope that that's how it pans out.
Dr. Ravi and Dr. Saranya, actually, what if this turns out to be the second wave, how better prepared are we to handle this crisis? In terms of testing, in terms of diagnostics, in terms of a vaccine, in terms of treatment protocols? Not able to hear you, Dr. Saranya. Volume. Turn on your volume.
I think she's muted still.
Yeah.
Yeah. Ramya, are you able to see me?
Doctor, I'm not able to see your video. I can hear you.
Just give me a minute. I'll leave and rejoin. There is some connectivity.
Sure.
In the meantime, Saranya can answer.
Sure. Thank you.
Yeah. Ramya, thank you. And the thing is, in terms of antibodies, we are detection tests. We do have wonderful tests available now, which actually help us identify if people have had an infection, the seroprevalence in a population, and also if the vaccine has actually been useful. But I think by and large, I think the fact that the vaccine has been rolled out in January 16th, and several of us have had one dose, if not both doses, are certainly going to be of great help in combating this, second wave, if it does, and it has risen, like Dr. Ram said. We do have states like Maharashtra, Punjab, and so many states. And Tamil Nadu also is, while I wouldn't say that we are seeing so much of an increase in our laboratory, what is disturbing is that the numbers are not going down as we had hoped for. So it's kind of remaining in a steady state, which is not a good sign. So sooner or later, we are going to be sitting and having to take active steps. So I think the vaccine is going to be a great help. And the fact that I think the state government has to take more active measures to ensure that we follow, strict hygienic protocols, hand sanitizing, and your physical distancing, and all of that as earlier, because like people have become kind of complacent about it because it was much lower in Tamil Nadu and in some of the other states. And now that they've had the vaccine again, that is adding an additional layer of complacency. So I think these two things are, we need to stress on them despite all the fact that the vaccines are available now. Dr. Ravi?
Yeah. Thanks for having me on the show. Nice to be with great friends like Ram and Saranya. I just have to say, I keep saying this, I'm not tired of it. SARS-CoV-2 is a new virus. There's only two ways you get immunity to the virus. Either you get infected or you get vaccinated. So let's be very, very clear that if you are not infected or if you're not vaccinated, be sure the virus will catch you. And that's where I want to echo what Ram said, saying that sooner or later, the virus will definitely catch you. As regards the second wave, I think I echo what Ram said. Remember, the general feeling is that we are over the hill. We are over the hill because for two reasons. One, there was a huge surge. And whenever there's a huge surge, people behave responsibly. That's one reason why infections come down. And whenever there is a surge, there is very aggressive testing, tracking, and tracing and containing the infection. Now, once the wave subsides, complacency sets in everything. The classical example is Kerala. Kerala never paid attention to aggressive testing since the beginning. They were testing at a constant level. When they had a surge, they did not, proportionately increase their testing. So I think, as Ram said, history has taught us for any respiratory pandemic, there will be and there shall be a second wave. Let's not forget that. So even here we will have, and we may not have it to the extent of the first wave, but definitely there will be a second wave. So these are the points I want to make. Over.
Right. Thank you, Dr. Ravi. It's interesting that you brought this point about testing, because if you look at the figures today, in some of the states where the numbers are going up, Punjab, Haryana especially, the number of tests have actually nosedived in the last week or couple of weeks actually, and the positivity rate is going up. Relatively, what do you see? I mean, in Tamil Nadu or the southern states, you did talk to us about Kerala, but what about the other southern states, Karnataka, Tamil Nadu, Andhra Pradesh, and Telangana maybe?
I'll start with my state. When we had a surge in between June and September, we, based on the number of positives, we were insisting on at least 10 contacts and all symptomatics to be tested. So our testing went to 120,000 per day. Now it has come down to 75,000 a day. And there's always this constant bargaining with technical experts whether we can bring it down because it's very resource intensive. My answer is only that if you do that, you will have a surge. Even now, I would say that minimum of 10 people have to be tested for every positive as contacts. Along with this, most importantly, we have to chase every symptomatic person and test them. We know that symptomatic individuals have a greater propensity to spread. We have done some extensive work which we published in Lancet eClinical Medicine, which basically in simple arithmetic says a symptomatic person on an average can give it to 14 individuals, whereas an asymptomatic can give it only to 3 individuals. So continuing testing people who have upper respiratory symptoms, flu-like illness is very important. And also minimum of 10 contacts. Ideally, you should be doing 20 contacts per positive person. That is the arithmetic. That's when you will keep it below 5%. So this is what I have to say to everybody about testing. Testing is the most powerful tool in our hands. If we have to be ahead of virus spread, then you should be testing minimum so many number of people for every positive patient, along with symptomatics. Over.
Dr. Ramsubramanian, would you like to respond to?
No, I think that's perfectly right. I remember during the peak which happened in Tamil Nadu, much ahead of the other states, there was a lot of pressure to come down on the testing because it was inevitable. When you tested more, you picked up more. And this put the state in a little bad picture because that was, everybody was vying at the time to control and keep things low. I still remember the trouble we had convincing people. And fortunately, at that time, I think the government understood the situation and they did tests remarkably well. So Tamil Nadu zoomed up, ahead of all the states. But because of that strategy, I think it has helped. And as Dr. Ravi mentioned, Kerala, I think, lost out on that. And that was the problem because we did a fantastic job. I would say we had a huge, pressure to show the numbers. It was natural. Politically, they had to show less numbers, but I didn't, the experts didn't succumb to it. And it was a very well done job, I would say.
Dr. Saranya, are you seeing rise in numbers in testing or people volunteering to test themselves?
No, right now, in fact, the thing is that we are seeing a lot of people who come in for testing. Almost 80 to 90% of them are traveling, and therefore they're getting their RT-PCR tests done. Of the people who come in for testing, very few of them are actually symptomatic as far as what they've told us. So that is the thing that's happening now. Our numbers are slowly creeping up. Like they've almost doubled in the last month from earlier, but the proportion of traveling to non-travelers or sick patients seems to be remaining the same. But I'm adding to what Dr. Ram said, when we were the first lab in the city to have got the permission to do the RT-PCR testing. So way back from March last year, we were testing people. And what was amazing was the corporation's efforts in tracking people. I mean, it was just superlative because I know that while we were cursing them for the fact of the pressure that we were under, but they used to follow everybody. The results would be out and in a matter of 4 hours, they had tracked the patient. So that was the speed with which they were tracking. It was a wonderful effort. And I think it got the desired results, but I think they need to keep up that tempo. They have to get back that tempo rather.
Right. That's, that sort of lays the emphasis on contact tracing and testing aggressively, continuing to do so. Of course, the important questions now, even if you do a sort of a dipstick in a small crowd of people, there is certainly vaccine hesitancy among the people in this state, certainly, and also possibly the rest of the country. Though some states have been doing a far better job than, say, Tamil Nadu or Kerala, for instance. What is the reason, Dr. Ravi, for this hesitancy to take a vaccine? Is it because of the communication that was done pre-launch of the vaccine, or is it the fear of unknown, as it were?
I think it's a combination of factors. The first and foremost is the fact that people ask, we are over the hill, why should I take a vaccine? Second factor that has contributed is there's this perception, this myth that these are fast-tracked vaccines, so safety is an issue. People forget that although it's fast-tracked, it has gone through minimum 3 phases of trial before it is out for human use. And before these 3 phases of trial, there has been a preclinical phase where animals have been given the vaccine, they have been challenged with live virus, there is protection shown. So these things are not communicated properly to people. The third thing is that there is, for every vaccine, there is always an anti-vaccine lobby. And given the social media freedom and the freedom and the explosion of information, these myths get propagated and put people on the guard. So I think that's a major issue that we are facing. Having said that, I must tell you that all the 6 or 7 vaccines internationally released for emergency authorization use have shown, by and large, a very safe profile. It's not that because of vaccine you are getting problems. With any chemical that you inject, you will have side effects. Let us believe. Every vaccine produces certain side effects. It's not that if you weigh the risks and the benefits, which what people should do, because there is no force in vaccination, the benefits far outweigh the risks based on scientific facts available today.
Dr. Ram, Tamil Nadu, it's really been at the bottom of the pile, especially until 2 weeks ago. And the big stumbling block has been the first batch, which is healthcare workers. Is there anything you can say to answer it? And why has there been better coverage in other states? Is there anything at all that explains this?
Vaccine. This is a mindset, and unless the healthcare workers change, it is very difficult to convince the rest. Because I still remember situations where the patient would be willing, but the general practitioner with whom the patient discusses would say, that this is a Western thing, you don't need it in India, we have natural immunity. So it's unfortunately, so the healthcare workers were more of a stumbling block in the early days, and I still feel that continues. Regarding public, the public feel that any intervention, treatment, no questions. But if you're looking at something preventive, it doesn't have the same impact unless there is a crisis, there is a huge issue, which we have got away with in Tamil Nadu. And that could be people are more relaxed. As Dr. Ravi said, we are over the curve. I think we have gotten, all of us will have immunity. They don't realize, and they expect that if they take the vaccine, they can go back to being normal, no masks, no nothing. So the questions asked is, if you say you have the, take the vaccine, you still have to mask, you still have to socially distance. It does not prevent you from having infections. It does not improve your lifestyle. So why take a vaccine? They don't realize that vaccines save lives. Actually, I should correct myself. It's not vaccine saves lives. It is vaccinations which save lives. So I think this message has to come from somebody who people look up to. So it could be a political figure, it could be a film personality, but a brand ambassador is very sadly needed in India who will say that vaccines are not enough, vaccinations are what it is done. And so far, it is very clear that vaccines are very, very safe as any other vaccines or even better. But efficacy, we still don't know. There are a lot of differences in efficacy. That we'll wait and see. But even if it, for example, gives me a 10 or a 20%, boost in my effort to stay healthy, I would go for it. It is not expensive. in real terms. So I think you need to convey the right message, which unfortunately I think Tamil Nadu has still not done it with the population who think that they've already, recovered and they are all fit and fine.
I just want to add, Ramya, one point. Ram very eloquently made simplified complicated factors. One point I want to make is one of the biggest gaps in knowledge that I've seen among healthcare workers, because every day I'm doing one webinar or Zoom call addressing concerns. There's a misconception that vaccination protects against infection. Let me make it very clear. All the vaccines released for human use protect against disease. That is why the insistence on continuing COVID appropriate behavior. You may not get the disease, but I can get infected, although I am vaccinated. I can transmit it to others, so I can be a source of infection. Till the entire globe of 7 billion is vaccinated, we cannot remove masks and stop social distancing. This is something people do not understand. And it's very surprising that the healthcare workers are the people who get half-baked information through social media and then take their decisions. It's very difficult. I'm sure if you offer it to the public tomorrow, the acceptance rate in Tamil Nadu and all these lower states will be much, much higher than in healthcare workers. Over.
Ramya, I'd just like to add to this. Again, our lab is the first lab in the city to have been given permission to vaccinate our own staff. So since last Saturday, we have been vaccinating our staff. Since everybody is a healthcare worker or a paramedic or a support staff involved. And in the first round, when we were, asked by the government itself that we could go and register and get ourselves vaccinated, there were just 14 of us of the 200 plus of the staff who actually volunteered and got vaccinated at MMC. But when this was offered to us last week, I have to confess very happily that about 120 of the remaining lot have actually got vaccinated. And Ravi, I need to thank you because I listened to your talk that you gave for the Sri Lankan Rotary Club. Your message I transmitted to everybody, telling them that, this is it. Either you have a side effect of a vaccine or we don't know how seriously you're going to be affected by the coronavirus. So I think that did have an impact. But to come back to the point I'm trying to make, I think there is a lot of lack of awareness, lack of information as well, because people really don't know a lot. And they were asking, I've had infection, so why do I need a vaccine? Or I have a comorbidity, why do I need a vaccine? So all these things they need to be educated on as well. In addition to the other factors that both Ram and Ravi said, there is a gap in information that needs to be plugged.
Fair enough. The other question I think very relevant in India today is whether we are heading for another lockdown. So a lockdown as we knew it since March 24th, is that warranted? Is that necessary? Or if that kind of lockdown is not necessary, is a more watered down version important, that if we see the cases climb higher? Before we get answers, may I just, I'm seeing a lot of questions on the panel. So just a few pointers to our colleagues. Once the discussion is over, we'll take another maybe half an hour to 40 minutes, and then we'll open it out for questions. I do request everyone to put their questions down on the chat box. We're looking at it, and I'm sure we'll have time for each and every question. Yes, Dr. Ravi, please, if you'd like to start already.
Lockdown is the last step, the last weapon that is used. So I'll start from there. Are we heading for a lockdown? I don't see it happening in the near future. Are we heading for watered down versions? Maharashtra has done it. You can see that. Partial lockdowns, night curfews, these sort of things. Whenever there is a huge clusters leading to community spread, one has to probably adopt that. But what we need to do is make sure that we get our act together in terms of testing, tracking, and tracing to full swing, focusing on symptomatic people and also conveying messages to avoid surge in infection. And there, the most important point is we know, everybody knows, but nobody understands that closed spaces and crowds are the super spreading events. I think that is where the focus has to be, and there it's the responsibility of both the public as well as the implementing authorities to ensure that such events do not contribute to super spreading events. We may have to see containment zones coming back, especially if the clusters. We went for a containment of apartment complex. You would have seen in the newspapers, Bangalore, there was a huge surge in one large apartment complex after a party. So these kind of things will continue. How long will they continue? Till everybody receives vaccination. So I see it happening for another year, not less than a year. Over.
Dr. Ramsgren, do you want to?
Yeah, perfectly agree. Lockdown is a draconian measure. We have learned several lessons during the first lockdown with relation to livelihood of people. So I wouldn't consider that as an option at all at this point. What I think we need is individual responsibility and civic responsibility. I think that's the only thing. So people have to realize they are masking not for them, but for the society, their family, people around them.
Right. So while we talk about this, Dr. Saranya, you mentioned antibody tests are now available. Very sensitive antibody tests are now both specificity and sensitivity. But the question is that, apart from RT-PCR, the bulk of the states have stuck with our RT-PCR. I mean, there have been other products in the market, including the Feluda test, the paper test, which ostensibly offer you an easier way of testing. Why haven't these picked up? Why have states stuck to, say, RT-PCR? Some states have also done antibody testing, but others have kept antibody testing to surveillance alone. What is the result for this, like people sticking like glue beside RT-PCR?
No, I think it's probably it is the fact that it is the international gold standard. So, and everybody has got the infrastructure now to do it. And there are better and better kits that pick up, you have multiple proteins that are being, targets that are picked up. So they probably feel it's more safe using an RT-PCR. And as for the CRISPR or any other tests that are there, I think the other test that has gained ground is also this antigen testing, the saliva antigen testing and the other antigen testing. But for some strange reason, the government itself hadn't given us permission to do it in Tamil Nadu. So we weren't allowed to do the tests. So we were only allowed to do the RT-PCR test. That was the only one. And then after a long time, they allowed us to do the antibody tests. And that too, they specified initially was only for serosurveillance, not for any other reason. So like when companies started approaching us wanting, to reopen and therefore wanting to get the stuff done, we had to speak to the corporation to see if we could do it. So the GCC has had a big role to play in, though we would have wanted. Plus again, I think the cost factor was one. And the costs of the RT-PCR tests have come down successfully over the last 1 year. So I think probably those played a role. As far as I see it. Ravi, could you add on to that?
Yeah, I would just want to make it very clear that nucleic acid detection remains gold standard. You cannot match that sensitivity by antigen tests. Antibodies development in COVID is unusually delayed compared to many other RNA viral infections. You will start seeing antibodies only 14 days after somebody is infected. So that makes it impractical for public health point of view, because if a test is going to be positive in 14 days, I could have spread to so many people. So RT-PCR or nucleic acid tests are and will remain the gold standard. Number two, over the year, we have really been able to build capacity for RT-PCR across the country. I think that was a phenomenal development that occurred, and automation has come in. and the costs have gone down. Like Saranya said, it was 1,500 for reagents for a test in March, April last year. It is now less than 100 rupees for the reagents of a PCR test. In fact, RT-PCR tests beat antigen tests in terms of cost also. So for these reasons, and antigen tests, the ones that are available freely in Indian market have a sensitivity ranging from 50 to 70%. So if it's positive, it's fine. But if it's negative, you have to do an RT-PCR. That is double testing. So I think for these reasons, practical reasons, RT-PCR has stayed around. Okay.
Dr. Ramsubramaniam, in clinical practice, if people come with, mild symptoms, I mean, they, or asymptomatic, but, they have a suspicion that they might have COVID, do you recommend the RT-PCR, or do you recommend that they wait? I mean, these are people who are not ill, they are not sick. Or do you recommend that they do the antibody test after a while, after a significant period of time?
No, a practical approach, what I follow is, if the person has significant comorbidities, if the person is obese, if the person is above the age of 60, I usually insist on an RT-PCR. If the person has mild symptoms, if the person is sensible, educated and responsible enough, by, evaluation, I usually tell them that this is probably COVID. We can do a test to confirm it, but even if the test comes negative, I would like him to be isolated at home for 10 days. So in other words, I tell them that I'm not doing the test to diagnose a condition. I tell them I strongly suspect the possibility. So even if the test is done, the management doesn't change, because these mild infections, they don't require any intervention. So the management doesn't change, but the awareness improves. Some of them tell us, no, doctor, we'll isolate ourselves for the next 10 days. I'd rather not do the test. There are some other people who say, no, I would like to know, I would want to do the test. So I don't insist, provided they are responsible enough to stay isolated at home. But if there is any doubt about this, I usually insist on the test.
Thank you, Doctor. Dr. Ravi, I'd like to come back to you about the question about testing genomic variants. How expensive process is it? Is it viable for states in the country to do regular genomic testing as they do perhaps in the UK or in European countries? Do we contribute to a pool of sorts, an international pool of sorts of genomic variants? Do we contribute to a pool? And how does genomic testing actually help us?
Okay. And thank you for asking the question. I'm just out of the steering committee of Indian National COVID Genomics Consortium, INSACOG, which is being established. Testing for genomic variants is very important in the current context when there is a second surge. Having said that, it's impractical to test every patient for a genomic variant, because we do not have still a simple test like RT-PCR available for genomic variants. The United Kingdom has developed a PCR using what is known as lighthouse primers from the 3 lighthouse labs, but that is not at a commercial level, it's at a research level that they are using. There are diagnostic companies working towards developing PCR tests for detecting variants, but that will take some time to get licensed and come. So on this background, what should be done? So the country has taken a decision that all international travelers shall be subjected to RT-PCR. If they are positive, the samples shall go for genomic sequence to 10 labs that have been established in the consortium in the country. And my erstwhile institute, NIMHANS, is where I'm sitting now, is one of the labs that has been identified there. The second set of samples will be, we will continue it. It cannot be a flash in the pan one-time activity, just to continue. So the decision has been taken to out of routine samples, 5% every day will be taken up for sequencing by this genomic consortium. Now, how do you pick these 5%? So my suggestion, which has been accepted, is that instead of randomly picking up, first priority should be given to clusters. Wherever there is a cluster, immediately that a proportion of samples should go for sequencing. B, when there are no clusters, if you are talking of a state, there should be adequate geographic representation of all districts. And C, wherever you are seeing a new clinical phenotype of disease, which Ram can certify, looks unusual, I would like to know whether it's a variant. That will be the third priority in these 5% that will be done. So this consortium is already functioning, but it's going to get formalized. They're all now facing the difficulty of resources. Hopefully the government will release the resources soon. And this is planned initially for 6 months to a year, because the virus will mutate and we'll have to keep track of the mutations in the virus and see which of these mutations add significance to both clinical medicine as well as to public health. I'll stop here. If you have any questions, I'll answer.
I think some questions are already lined up, which we can take in a bit, perhaps. The other question that is primary, I mean, it's on discussion forums and WhatsApp groups for sure, but also being deliberated on by the government is the return of children to school. Now, a significant group of people from 9th to 12th standard are going to school almost in every state. Colleges are back, and we saw initially some clusters develop at colleges at the mess level primarily. So looking at the numbers today, what is your advice for the government? Do they hold on to opening up more classes, coming back to school, that is real time? Or how does it, because there is no vaccine for children. At this stage, the vaccine is not recommended for children. So what is your take on this, Dr. Ramsubramanian?
See, I don't think the question is, shall we open the school? The question is, how shall we open the school? People don't realize the phenomenal psychological impact the last 1 year has had on children. We talk about the safety, we adults always look at, how to protect children, but we don't realize the damage which psychologically the children have undergone in the last 1 year, staying away from school, working, online. I don't think it is conducive for a good development in the long run at all. I mean, probably psychiatrists may, talk better about this. But I see patients who are children who are so badly traumatized by what has happened that I don't think it's, we have done enough of it. I think what we should now look at is, we know very clearly that children are not at risk of developing serious infections if they get the virus. We also know through modeling studies based on real, evidence that the transmission of children to others is also quite low in the household. All in all, the risk both to children and to the family through them is actually less than what we had thought of earlier. So keeping this in mind, I think we need to look forward to setting, standards or, protocols to ensure that this risk is even further minimized. I think that is how I would look at it. I'm a strong believer in opening schools early. I know I may get a lot of flack for this, but I think the way forward is to ensure safety and get on with it rather than, trying to protect children, which may be harming them more in the long run.
Yeah, but I'm sure all the parents are going to be thanking you for this.
Obviously not. For example, in a survey done in a school I know, almost 80% of parents, the school offered to open up with appropriate precautions, and 80% of parents were not willing to send their children.
Right. There are other concerns about vaccinating for persons with comorbidities that have come up, and seniors. Now the government is going to open up vaccination for senior citizens, actually 50 plus, but definitely senior citizens. And there are a lot of doubts about, my dad is a heart patient, he's on, this person has beta blockers, this person is undergoing dialysis, this person has an autoimmune condition. So is there an answer for everyone, one answer for everyone, or would you advise people to check with their consultants, with their physicians before they go ahead for the vaccines? Yeah, Dr. Ramsubramanian, Dr. Ravi as well, please.
The simple answer is just do it. We know very well that it's a kind of a paradox. People with comorbidities are at higher risk of complications and death. And we know that the vaccine minimizes or decreases the chances of hospitalization and death. So it is a no-brainer. If you have comorbidities, the reasons for vaccination is much, much stronger. So the next question is it safe? Absolutely. We have seen that. I will give you a personal. My dad is 90 years. He had both, he's a doctor. He had both his shots, in the last 1 month. We know that the vaccine is safe. What we don't know is how efficacious it will be in a person who is 90. But as I said, if it improves my chances by 10%, that is 10% more than I already have. So I don't think there is any word to, argue at all. The only point is, unfortunately, the use of blood thinners,
right,
in colloquial language has actually harmed the process of vaccination, because people tend to equate blood thinners with aspirin and clopidogrel, which almost 50% of people over the age of 60 are on.
Yeah.
We are not referring about that. Blood thinners typically mean the anticoagulants, azithromycin, warfarin, which really increase the chances of bleeding. So they should be careful, not because it causes harm, but you may develop a bleeding or a blood clot or a hematoma in the arm when they get vaccinated if their bleeding parameters are a little high. Whereas aspirin and clopidogrel is perfectly safe. So as far as I'm concerned, I don't think there is any thought about vaccinating. We are only worried about how effective it will be, that we can worry about later.
Thank you. Thank you for the very clear statement, Dr. Ram. Dr. Ravi?
I entirely echo what Ram said very beautifully. I just want to add that what you see in social media is people flashing package inserts. Let me tell you very clearly, if I am a vaccine manufacturer, I will put 20 conditions saying I don't know if it is safe, primarily because I do not want to pay compensation if something happens. That doesn't mean that the vaccine is not safe. If you look at hard published data of phase 3 trials, many of these vaccines have actually included people who are elderly and with comorbidities. They have not reported any extra side effects and extra complications in these compared to the other apparently healthy group. So I think the message is very clear. Go ahead, take the vaccination, because you require it more than a healthy person who is in the age of 30 to 35 and has no comorbidities.
The other question, Doctor, and Sarani as well, with the emergence, again, is with the emergence of these very differentiation, the different strains of the virus, there's a question whether the antibody generation from the vaccine will be effective. Will it be, because there is a broad-based antibody development. Is that sufficient when, your vaccine strain becomes more severe, or, it spreads faster, causes more critical conditions for the patient?
The answer to this is in 2 points I want to make. First, it's an emerging situation. It's a very dynamic situation. It's unfolding. For many of the vaccines, we know that the wild type that is circulating prior to the emergence of all these new variants, the efficacy has been established. Whatever the claims I have published, and it's out in the media and in public domain.
Right.
Most of these vaccines do protect against variants as well, albeit to a much lesser extent. That is the emerging data. Having said that, most of these vaccine platforms are advantageous, excepting the killed vaccines, that you can tinker and get the vaccine altered to meet the needs of emerging variants, but that will take weeks to months. So that is also ongoing at this point of time. Killed vaccines, broadly speaking, offer a broad immune response, because most of the other vaccines that you're used today for COVID are subunit vaccines. I classified them as parts of the virus, either in terms of the protein or in terms of the genetic material for spike protein, like the Pfizer and Moderna, or it's like virally vectored. That means spike protein is piggybacked on another harmless virus. So these proteins are subject to more immune pressure because they are displaying only some antigens. Killed viruses traditionally, it's the oldest platform, more than a century-year-old, display a variety of antigens to the immune system. Theoretically, they should have a better advantage. If you can't catch the dog by head, you can catch its tail, right? Some other protein. And we do not have sufficient information on the protective nature of other proteins. Everybody has focused only on the spike protein. So I would say conventional wisdom says killed vaccines, whole virus vaccines should be able to tackle variants better. The only piece of evidence I have to say that is Covaxin has been neutralized with samples from people from the clinical trial with UK variants, and it has neutralized to the same degree. But that is not true of South African or Brazilian variants. The other piece of evidence we have published is that South African variants, the virally vectored Oxford AstraZeneca, did not give the, it gave much less protection than it does to the wild type that is circulating globally. So I'll stop here. If you have any questions, I'll answer.
I think with with just one point, if Dr. Ravi would like to bring us to speed on the various other vaccines that are available. We're hearing of a single dose. Yesterday we heard of a single dose. We're also hearing of a nasal vaccine in the process, in the works. What are the what's the good news on this front, Dr. Ravi?
Okay, I can't say good news. There's a lot of promise. Johnson & Johnson is using a virally vectored vaccine, which is undergoing clinical trial with a single dose and a double dose. Initial results in the single dose seem to be promising, but we'll have to wait for the trial to be completed. That's regarding doses. Regarding the other vaccines that are in the pipeline that are promising, there is a DNA vaccine in India being made by Cadila, which is undergoing trials in phase 1 and preclinical studies. It showed tremendous promise. We are having our own RNA vaccine that is in trials. We are having our own indigenous vaccine going, nasal administration that is going to start probably in the next couple of weeks. Nasal vaccines uptake or acceptance is far less compared to, generally speaking. We have seen the flu angle, and Ram can substantiate less, but the advantage is it's easy to administer, but it requires a certain amount of building competence and acceptancy in the public. Nasal vaccines come with a promise, at least in the preclinical state, the data I've seen, of sterilizing immunity. What is sterilizing immunity? Because it builds up local immune response, it prevents infection. That's what is the experience in preclinical studies. Whether it will hold in human trials, we'll have to wait and see. Over.
Thank you for that, Doctor. I think we can move to the questions. First question is from Vishwanath Pilla from Money Control. Its question is to Dr. Ravi or Dr. Ramsubramanian. Is the second wave in Maharashtra in any way linked to possible new variants?
I'll take that question. There is absolutely no evidence to say that there is a new variant in Maharashtra. There have been 2 amino acid changes noted in the spike protein, but that does not constitute as a new variant. There are several conditions. All these were triggered by super spreading events and subsequent lack of testing, tracking, and that kind of led to the spread of these. It is not true that we have our own Indian variant that has emerged. The amino acid mutations that have been seen in Maharashtra have also been seen in other places. We have been doing genomic sequencing at NIMHANS. We have found both the 440 and the 484 mutations isolated in variants that have been circulating ever since post-lockdown period. So these are all social media and uh, messages that are confusing people. There is no variant that has a propensity to spread higher that has been identified in India. That's the statement I would like to.
Dr. Saranya, so I think we have covered a bit of this, but maybe you'd like to take this. Do our RT-PCR test kits detect the new variants that are emerging? Do we need to tweak our testing if the new variants dominate?
As far as the RT-PCR kits are concerned, yes, they do pick up the new variants. So there is no problem about that because they all have different targets. So you have, every kit has a minimum of 2 targets apart from a group, what shall I say, a corona group target. So you do have the E, you have the N, you have the RDRP, ORF1, all of these. So definitely it will be picked up somewhere, because the mutations happen mainly in the spike protein area. So you do have the other targets to go by. So they will be picked up with the current RT-PCR kits.
Right. So Anuradha Mascarenas from Indian Express Pune. So ICMR has said that there is no link with variants. So can you please tell us about why the spread is so fast in Amravati, Yavatmal and Pune?
I already clarified that. It is primarily because a series of super spreader events led to community spillover and testing was not in pace with the spread. Now testing has been stepped up. I'm sure in 4 to 6 weeks you will see the whole situation controlled if they continue testing, tracking, tracing aggressively.
I would like to add one point to this, in the sense it has been very clearly shown that people can get reinfected, especially younger people who have a very mild infection may not mount an adequate antibody response. And these people, they get a reinfection. Reinfections are almost 50 to 70% so mild that the person doesn't know. But the primary infection, only 30% or so develop significant symptoms. But the problem is these people may have high burden and they may continue to transmit the infection. So it is possible that those who had a milder infection during the first wave may have a reinfection and contribute to spreading virus.
So, also request for our colleague who put in questions here if you want them answered. So this is again, I think Vishwanath Pilla. Yes. So, Dr. cases are waning. Is more scope for SARS-CoV-2 mutant variants becoming a dominant source of infections?
Corona SARS-CoV-2 is an RNA virus. RNA viruses have an enzyme known as RNA polymerase, which is responsible for making copies of its genome. Unfortunately, God has endowed this enzyme with a very poor proofreading ability, meaning whenever it copies itself, it makes mistakes and it is not able to detect the mistake. So every time a coronavirus strand multiplies, there will be a nucleotide change. But it depends on whether it results in alteration in the protein. And even if it alters the protein, what kind of amino acid it has changed. Now, this is the whole sequence of how mutation occurs. The second reason why mutations occur is because of immune pressure. If a large proportion, if you assume, of a population is already infected, and Ram just made a point, again I get infected, the second time I get infected, or I'm immunocompromised, or I have some other problems, that puts pressure on the virus. This is what we call immune escape variants. So immune escape variants will continue to emerge. Mutations will continue to occur. We have to learn to live with it. We have to have, we always have to be ahead in terms of our testing, our detection process, and our containment measures. Over.
Yeah, Dr. Ramsubramanian.
Yeah, I think it was very nicely said that the immune response, if it is not robust enough to eliminate the virus, it can engender development of variants through mutation. So your immune response should be very strong to minimize the virus replication. That is the reason, in fact, one of the reasons we know there are a lot of questions about vaccination where it is said that evidence says that it is better to give the second dose of, for example, the Covishield vaccine after 12 weeks. The immune response is better. But if you look at the arguments against it, it is seen that when you give the first dose, the vaccine response comes up in 2 weeks and probably definitely lasts for 4 weeks or 6 weeks. And after that, there will be a waning of response, which when you give a second dose at 12 weeks will again boost the response for a much higher level. But if the person has a low antibody titer after say 6 or 8 weeks, between 8 and 12 weeks, when the virus level is low, there can be a reinfection, there can be an infection happening. And this low level of immunity can again increase the possibility of variants developing. These are all theoretical reasons, but that is a reason why there is not a complete unanimity in ensuring that we make the 12-week interval instead of the current 4-week. So there are other reasons to think of. So any weak immunity can increase the risk of variants developing.
Right. Thank you. This is a question from Vatsalya. Dr. Saranya, are you seeing an increase in students coming in for testing?
Only students who are going out of the country, but otherwise not anybody from here. A few numbers trickling in for going to school, the 9th and the 10th standard children, but not many at the moment. But I think it is steadily increasing. It's not many though.
Right. Same person's question. Dr. Ram, do you think school workers should be classified as frontline workers and prioritized for vaccination?
Absolutely. Anybody who comes into contact with a significant number of people, which increases the risk of spreading and getting the infection, is a frontline worker. So yes, I think they should.
Right, thank you for that. We have a question from Ranjini Madhavan, the New Indian Express. Dr. Ravi, have any variants been found in the 2 colleges and apartment cluster recently in Bengaluru and Mangalore?
Okay, the 2 nursing college clusters, one in Mangalore and one in Bangalore, have sequencing has been done. There are no new variants. Whatever was been circulating earlier is the same virus that has been found in both these clusters. We did the Bangalore Nursing College sequencing, and NCBS, the other lab in Bangalore, did the Mangalore samples, and they also did not find any UK, South African or Brazilian variant. The apartment complex samples are right now on the sequencer. Maybe by another 2 days, we will get the results from our lab.
Thank you. There's also, I think Anuradha has also said this, but I've missed it. Scaling up genomic sequencing tests would be costly.
Yes, at this point of time, genomic sequencing is very expensive. It varies anywhere between 8,000 to 20,000, depending on the number of samples you're doing sequencing. If you do more than 50 samples, your costs come down to around 8 to 10,000. If you're doing 10 or 12 samples, your cost can be as high as 20,000 rupees. That's precisely the reason why the INSACOG, Indian National SARS-CoV-2 Genomics Consortium, has been established. And it is, as I said, it's not practical to do every sample. There is a strategy that the government is looking at on what samples to submit for sequencing.
So at this point of time, Dr. Saranya, private institutes are not really doing any genomic testing for the COVID.
No, we're not.
Yeah.
But the one thing that I must comment here is I think I haven't seen in ever since I've started working this kind of speed with which kits have been manufactured for COVID detection or now for antibody detection. It's just amazing because sitting here, we've had the chance to validate so many different kits, and they're all good. I mean, it's great. It's really great. We've done a terrific job, I would say.
So since we're on to the subject of kids again, how soon will the clinical trials on a vaccine for children, is it on? Is the process on still, or is it due to start? What are the ethical concerns of using the vaccine on children?
I'll tell you what I know. There are 2 vaccines that have started trials in children. Not in all children, but in a group between 10 to 18 years. There's the adolescent, semi-adolescent group. It is still not gone down to less than 10 years. Those results will be out probably in May. April, late April, early May, you will get the results. Ram, you want to add?
No, I think it is, so far safety has been reasonably well established. So studies are already on, and we should know soon.
So are there any other questions that, yes, Vishnath Pilla again. Why is the development of, why did the development of therapeutics take a back seat?
See, viral therapeutics always cannot be fast-tracked because you will have to have a very specific target or a drug that targets only a particular part of the virus, not in any way harming the host. And that is a dream. That's a dream. You get it for very few viruses, like herpes simplex virus, where the treatment was so beautifully done that it attacks only the viral proteins and the viral replication, not the normal cellular replication. So that remains a challenge. So I think the only kind of therapeutics that people have fast-tracked and tried is to use, which Ram was mentioning about monoclonal antibody therapies, trying to neutralize the virus. But then these are more in the preventive domain rather than in the therapeutic domain. And the other approaches for therapeutics in COVID people have taken is to minimize the host immune response, because the disease is predominantly because of host immune response. The severity of the disease is more to do not with the virus per se, but the way a person's immune response reacts. So that area is again very difficult to develop therapeutics. Ram, you want to take it?
Yeah, I don't think it took a backseat. There have been a lot of studies going on. Unfortunately, there have been very few successful candidates. It is just sad. I don't think it was because of lack of trying.
So, as researchers at some level, all of you, what do you think of this whole, rush to publish on, pre-pub, non-peer reviewed, this glut of pre-pub publications on COVID itself? I mean, is that a good trend? Just because it makes it very difficult for journalists sometimes. Earlier, we used to say no pre-pub at all. I mean, just give me a peer-reviewed article. But now, I don't know, we find it difficult to ignore that aspect. What do you think?
I think one has to be the person who generates the new information and put it on any of the archives, like medRxiv or any of the other archives, should not make it public, because it's still not peer reviewed. This is a responsibility, my social and moral responsibility, that I don't start touting my findings, research findings that have a huge bearing on the disease or its diagnosis or its prevention or so. But having said that, this is a free world, so people access everything. And people who access information, who process information, should be very clear of the difference between what is peer-reviewed and published versus what is in medRxiv or any of the other archives. That, I think, is a huge challenge. How are you going to educate people? I leave it there. Ram?
Yes.
I agree in the sense that during emergency situations, it calls for, it's like the emergency use authorization. You have to have some way in which we can get the information faster, but there should be some responsibility in promoting or accepting. All that is also part of it.
There's another question from Sunita Rao. Any study being done on the AEFIs reported across the country? And there are cases of GB syndrome reported from Karnataka. Vaccine.
There are AFI committees which are looking at the state level, in fact at the district level, at the state level, and at the country level. The analysis is ongoing. I am not a member of the AFI committee. I'm not even qualified to be a member because I'm not a clinician in that sense. They are looking at it. Having said that, there are, Sunita has raised a question about GB syndrome cases. If you go back to the publications of Covishield, Ram can correct me if I'm wrong, there has been a small proportion of people who develop neuroinflammatory syndromes, which has been associated to the adenovirus component in the vaccine, not due to the SARS-CoV component. And this is something that, and neuroinflammatory syndromes following vaccination is not specific to COVID. We have had whole lot of it with influenza vaccines. Older generation influenza vaccines used to have so much of Guillain-Barré syndrome. So whenever you make a vaccine, and depending on what platform you make it, if it's an egg-based platform or a cell culture matrix platform, if it is a vectored vaccine, there are going to be some side effects. So that one has to accept. Now,
yeah, I think what we look at is, if for any vaccination or any intervention, if the overall impact is much, much beneficial than risk involved, you proceed with it. So there will be people, but it's a simple question of measles vaccine. If you give measles vaccine, the neuroinflammatory syndromes happens in, say, 0.1%. And if you don't give the measles vaccine, 5% of children die. I think it is an easy mathematics. So yes, there is a problem involved. The same thing goes for drugs also. I've seen people die because of ciprofloxacin allergies. They develop a severe reaction called toxic epidermonecrolysis, and this can kill a patient. I have had several cases die, but does it mean that we don't use ciprofloxacin? No. That is a very small risk. It's like driving on the road. Don't we die in road accidents? But we try to take all the precautions necessary. And the second is, I see a recent trend towards maybe the anti-vaccine lobby or maybe enthusiastic people, but in the social media, vaccines are being branded as related to side effects. Yes, they are related, but is it causal relation is what we need to look at. Recently, there was a child who was given a pentavalent vaccine in Tamil Nadu who died following a few hours later, and it was put up as, child given vaccination dies. The message this kind of press release conveys is very, very sadly, very, very, negative. It was later found out the child was already suffering from bronchitis and probably pneumonia and then succumbed to it. It was a less than a 2-year-old kid. So I think before we publish news on these things, there should be proper evaluation done so that the public don't get the wrong message. When you say serious adverse events, it refers to certain adverse events, certain events which a person who's on a vaccine trial can get. That doesn't mean that the vaccine is causing the effect. So we need to get more information before, but unfortunately in the first day, kids die of vaccination. And then 5 days later, studies have shown that the vaccine was not related to the death. So, that is missed. So I think there should be some responsible, responsibility from the people in the press also. That's my earnest request.
And one more point I want to add is that fortunately, people recover, majority of them, most of them recover from these neuroinflammatory syndromes over a period of weeks. It is not that it maims and debilitates or kills people. So that is something that should be kept in mind. And who will get it, who will not get it is $1 million question.
Right.
In fact, the other day, there was a runner on one of the leading TV channels, which said, so many vaccinated, 97 deaths. I mean, so it looked as if the deaths were due to the vaccination. They were talking about two completely different things. But the way it was put will make anybody kind of run away from vaccination.
This happened in Norway also, the people who
Yes.
elderly people. And when they looked at the statistics, even in normal times without vaccination, 400 people died every month or 400 people died every week. So the vaccine didn't do it. So, but this is unfortunately lost with the subsequent, the impact of the initial message takes the cake.
Right. There's a question from Baban Lihinar. I'm sure if I said that right, but I think you've answered that. I think, Dr. Ravi, in Maharashtra and especially in Mumbai, what could be the reason for increase in COVID-19 cases? You did say super spreader events, but if you want to take that question.
No, I would just say these are the super spreader events spilling over to community. That's what has led to the surge.
Right. So with the vaccination opening up for the general public, as it were, and the private sector is going to be involved, do you think there is a case to be made for making the vaccines affordable, for fixing some tariff so that, or do you think that people who can't afford to pay for it will anyway go to the government sector? What's your take on this?
Well, judging by what we've been hearing last few days, because since this news has been coming in, a lot of people whom we know have been saying that they'd like to come here and get vaccinated. And we are obviously going to comply with the government rules the minute they let us open to the public. But having said that, I think the government has already fixed a tariff. And I think they have told us that I think we can charge 300 rupees for the vaccine. That was the latest thing that we heard. So, and even I think over the counter, when other people, private practitioners or any any clinic that's offering vaccination offers it, I think the price is going to be under 1,000 most certainly. So I don't think it will be over that. So I think they've already kind of fixed it, and this is the communication we received. So we will be complying with the government regulations, of course, once we receive our notification.
That's what we've been hearing as well. 300 per dose is what we've been. So not officially, I don't think it's
not yet official. And I think a lot of people will come to the private sector mainly probably to avoid crowds.
Right.
They probably will feel that there'll be a bigger crowd in the government hospitals. I don't know. I mean, we have to see, but we've got our systems in place. We've got a beautiful center all set up, ready, waiting for these people to come.
Right. So at this stage or at any stage, is it safe for this vaccination to be done in a health setup, in a healthcare setup? Or, because otherwise for children, routine immunization is done even at the clinic where there is no support, larger support for, oxygen or anything else in case the child were to fall ill. But for COVID, what do you think?
We've got everything.
I would like to respond saying that, the way the vaccination process was rolled out, actual vaccination process, I'm not talking of the registration, the COVID and the glitches there, has been done exceedingly well. Primarily for the reason which Ram mentioned. This is the world's largest adult vaccination campaign. And with all the concerns that people have, they've set up 3 different rooms. It would be sad if those procedures are not adopted in private centers. So one has to first make somebody sit, talk to them, verify their identity. That's the waiting area. There should be an injection room and definitely half an hour observation after vaccination. I think this should be made mandatory. This is my personal opinion.
Right, fair enough. So I think there are no more questions and we've had a rather fulfilling session. I'm sure I have to run back to their pressing tasks. So thank you very much for this very, very enlightening conversation. Like a friend of mine says, COVID is sort of like the revenge of science. Everyone on the street is now talking about RT-PCRs and about how to test and what to do and AEFIs. So it's very, very interesting that you could provide us clarifications on a number of subjects that we are constantly debating even in newsrooms. So thank you very much, Dr. Ravi, Dr. Ram Subramaniam, and Dr. Saranya, and to Neuberg for having facilitated this sort of freewheeling discussion on the issues related to COVID. Thank you so much.
Thank you. Thank you very much.